So you all saw the data on the AQUILA trial. This is a large randomized trial, and what was included in this trial was high-risk smoldering multiple myeloma patients. I think part of the challenge with smoldering myeloma trials is we are continuing to redefine high-risk smoldering myeloma. When this trial was accruing, it did not necessarily include the slim crab. It did include slim crab, but it did not include the Mayo 2220 classification. And what you see out here was a great study. When you have randomized patients to Daratumumab versus observation, the patients who got Daratumumab had a progression-free survival benefit and also, in fact, an overall survival benefit. Now, when you dig deep into this, that survival benefit mostly is relevant to patients who had ultra high risk disease by the Mayo 222 criteria. So I think most of us would argue and agree that those are the patients who need to be treated. Now, should we call them really high risk smoldering myeloma, or can we begin to call them multiple myeloma and treat them as if it is multiple myeloma? The jury is still out there. You have data with a quadruplet, for example, as well as with single agent, but I agree completely. That's a subset of patients who needs to be treated. Now, how you decide to treat is up to you. There was data which was presented with 4 drugs also at this year's meeting, as well as with Daratumumab. And I think most of us are moving towards treatment for sure. The choice is whether you want to start with low doses of treatment or you want to give patients everything. I think the other really interesting study to me in the AQUILA trial was it was fixed duration. Even though it was single agent, it was 3 years of Daratumumab. And, the big question is going to be, are we going to be changing the natural history? The good news in the AQUILA trial is even in the control arm, we really did not see organ-defining endpoints like bone disease and kidney disease. And that, I think, is huge. So we've made a step forward. We did see anemia, and most of those patients weren't treated right away for the anemia as well. So watchful waiting does play a role. I think it is up to us now to really risk stratify patients really quite well so that we know exactly who needs treatment and who does not need treatment. So this whole debate of whether to treat or not to treat should go away once and for all. There was data also, I'm just going to add one more thing. It was on the basic science side, which actually looked at the genomics of smoldering myeloma and multiple myeloma. And that data suggested that we should get rid of the word smoldering myeloma because the tumor cells in smoldering myeloma look exactly like myeloma, and they should be considered multiple myeloma. So that's part of the reason why this debate still goes on and on and on.